So draping, he's cheating for me. He put his knees up in the hook lying position for me, but this is how you, this is how you would want your patient. So now with the pec, you have two different fibers that you're wanting to look at. You have the sternal and the clavicular head. So when you're doing, if you pull the card and you get pec major, blah, 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 blah.
So I've got my essay written.
Sorry. That was me.
Yes, Scott?
Yes, God.
So if you pull pec major, I can't remember if we ask you specifically clavicular or sternal fibers, but if we don't ask you specifically, expect to do both fibers. Good? I need to grab my goni, excuse me. So, like your lat MLT with your pec MLT, you can do, I'll show you both ways of how you can measure it. Again, you can either measure with the clavicular fibers, you can either measure the angle of the arm to the table, or you can just take a measurement of like your arm is 7 centimeters from the table, or whatever the centimeters end up being. Does that make sense? I'll show you both. So for clavicular fibers, you're going to have the shoulder abducted to 90. Oh, can you?
Yep.
Sorry. There we go. Thank you. So externally rotated, shoulder abducted to 90 degrees. Again, please use your high-low tables. This table is making me so mad, but I would have the table up higher so that you can save your back. And MLT, feeling for that muscle resistance, you're going to keep the elbow extended. And I'm, again, palpating at the shoulder, not so much stabilizing, but palpating if there's any kind of compensation. If he's tilting, you're also wanting to check in with your patient. Any pain there? Feeling okay?
Yep.
What kind of compensations might you expect or might you be looking for? If I have an external rotation, might start coming into internal rotation, might start some of that like shoulder shrugging, kind of trying to roll towards the, I'm sorry, somebody over here was saying something.
Or like bringing the torso.
Say it loud, I'm so sorry, you have to say it louder.
Okay.
Loud and proud.
Adduction, or like bringing the torso towards you?
Yeah, so like rolling over.
Yeah.
I think we covered most of that. So keeping them into external rotation, abducted to 90 degrees. I'm doing the clavicular portion. And then coming down towards the table. You okay?
Yeah, I'm good. Yeah.
Breathe. I would be testing the unaffected side first before the affected side. I'm starting to feel that pull. Can I actually have you move that way a little bit? Sorry. Because I want to be able to measure to the table. Sorry. Yeah, you're coming into horizontal AB, alpha bravo AB abduction. Starting to feel that there. You can support the arm there, squat down. So for this, if you're measuring, I don't even know if you can see with my big fat head, I'm very sorry. You're going to be measuring, the fulcrum is going to be at the acromion. Your moving arm is going to be towards that lateral epicondyle. Stabilizing arm is going to be parallel with the ground or the table, whichever way you want to think of it. And here he is 11 degrees from the table. Or if I don't want to mess with that, you can measure. It's a little bit harder. You're going to measure from the lateral acromion to where the table should be. Depending how far over you're able to get him from the table, then you can actually get the tape measure or your goni, whichever you're using to touch the table, or you can just say like, this is coming off parallel from the table to the acromion, or excuse me, to the epicondyle. His lateral epicondyle is 11 centimeters from the table. Does that make sense to everyone? How you can do both ways to measure it.
Mm-hmm.
So that's the clavicular. For sternal portion, you're going to bring him up to about 130. Does it say 130 or 160? Sorry. It's about 130. We're not asking you.
135.
135. We're not asking you to take a measurement and say, oh, he's at exactly 135 degrees, approximately 135 degrees, because what you really want to do is just imagine how those fibers are running of the sternal portion of the pec major. So you can see that they're kind of running in that direction. I'm so sorry. Thank you. They're running in this approximate direction. So same thing, external rotation, supporting the arm, feeling at that shoulder to make sure that we're not getting any kind of compensations, bringing him down towards the table until I feel that first resistance. This one, it would be much easier to measure. I would recommend just measuring from the table. Again, that lateral epicondyle to the table. He's at 9 centimeters here. You can also still do the method where you measure the acromion and measure that angle, and he's at 7 degrees, or no, what is that, sorry, 13 degrees of, the angle from the table is 13 degrees.
The angle from the table.
Yeah, because I'm measuring from the table. It's kind of a horizontal abduction, but just angle from the table.
This is for the clavicular.
Sternal.
Sternal.
Sternal. So clavicular is 90. Sternal, 135. So you want to think the opposite of the way that those muscle fibers are running. So the clavicular runs parallel with the clavicle. Sternal kind of runs at that angle with the sternum. So now those fibers are lined up with the sternum.
Right.
Did you externally rotate for the sternum?
Yeah, sorry. Forgot to mention that. Questions about Pec Major MLT? Okay, can I have you sit up for me, please? So then the last one we're going to be doing is Triceps MLT. You can give your patient a little bit of a toga. Patient sitting with the high-low tables. I can't do this with this table, but again with the high-low tables, when your patient's sitting, make sure their feet are on the floor. That's one of the patient position points that you'll be getting on your practical. Patient sitting, having him sit up nice and tall. I'm trying to see which way the camera best can see. I would probably be standing in front of them, but you're gonna have them come into full shoulder flexion. So just shoulder flexion, supinate, oh wait, I forgot, supination first. So we're doing triceps, full supination at the forearm, externally rotating, and then coming up into that full shoulder flexion. Any pain? You feeling okay there?
Yeah.
Remember to breathe. And then once we're in that full shoulder flexion, I'm probably stabilizing a little bit more here, just to make sure he's not arching his back or doing something weird, stabilizing at the elbow to make sure he maintains that supination external rotation. And then from here, holding that humerus, I'm going to gently bring his elbow into flexion until I feel that muscle resistance. And then you're going to measure the elbow flexion. So lateral epicondyle towards the acromion, towards your radial styloid process is your fulcrum, stabilizing arm, and moving arm. Everyone good on that? And I was showing some of you, I don't think I've showed the whole class. The best way to move this is to use your thumb to move the moving arm of your goni. So that way your fulcrum is where it needs to be, your stabilizing arm is pointing to where it needs to be, and then you just use your thumb to make those little adjustments. And then here I have them at 114 degrees of elbow flexion. Just relax.
Is there an lower range for that?
Compared to the other side. MLTs compared to the other side.
Oh, that's right.
Question on those two.
So you said supinate the arm and then externally rotate
Yep.
the shoulder, same as
Yep.
before.
Yep. Flex. And then max flex. Or not maximum, but where you feel that muscle resistance.
And then you said when you flex the shoulder, are you taking that to end range?
End range. So with all MLTs, you want to go to the end range of the other muscle actions to put that part on the maximum stretch, and then you're measuring the last thing you're moving. So I'm not going to measure supination, I'm not going to measure external rotation, I'm not going to measure shoulder flexion. The only thing I'm going to measure is the elbow flexion that I can get.
Gotcha.
Does that make sense?
Mhm.
Yeah.
Now, if I've done an elbow flexion goni and he has 150 degrees of elbow flexion, and I do an MLT and he also has 150 degrees of elbow flexion, it just means that his triceps aren't limiting him. Does that make sense?
Mm-hmm.
Questions on those? I do want to show you goni for elbow flexion extension before we break, because those are easy, and then we can move on. So I'm going to have you lie on your back for me, please. Is there a towel roll? I don't remember. Okay. Does anyone have a, may I borrow this towel roll?
Oh yeah, of course.
Okay. And then can you scoot that way?
Okay.
Okay.
You have valuable.
So elbow flexion extension, very easy. Patient's going to be supine. Still want them draped and exposed, or only exposing the area that you're testing. I'm going to put a towel roll, kind of a half towel roll underneath the elbow, just so that his humerus is in line with the thorax. He's not in any shoulder extension. So my normal expected range of motion is 0 degrees of extension, 150 degrees of flexion. The fulcrum is going to be your lateral epicondyle, your stabilizing arm is up towards the acromion, and your moving arm is toward the radial styloid. So for elbow extension, the towel is really doing most of the stabilization, so you can either palpate at the shoulder, you can just keep your arm kind of here at the elbow, whichever you're most comfortable with. Relax, remember to breathe. And again, I would also bring the table up so that I'm not squatting down, but relax, relax, relax. What kind of end feel would I expect with elbow extension?
Hard.
And why is that? The olecranon's going to be hitting it into the humerus. This is actually a common one where you might get hyperextension. There's a lot of people out there that have hyperextension of the elbow. And so again, a little bit of an overpressure. When I give him overpressure with elbow extension, there is no extra movement, because that's that hard stop, that bony end feel. I'm not getting any extra movement. Here, if I continue to pull in, then you're starting to get shoulder anterior tilt. You can maybe get some pronation compensation, so just watching for those kinds of things. But I'm stabilizing here at the shoulder. I'm not getting any extra movement. It's that hard end feel. He looks like he's at 0 degrees. Any pain there? So I'm going to bring him back. I'm going to preset my goni to 0. Bring him back, palpating those bony landmarks. And he is indeed 0 degrees elbow extension, normal 0 being 0 degrees. Questions, comments, concerns about extension? So also in the same position, bringing him back. What kind of end feel would this be?
Soft.
Why is it soft? Because it's tissue. Sometimes if you get just a very slender person, whether they're elderly or just a slender person, you might actually get more of that firm end feel, so you're going to get some more of those ligaments resisting before you start hitting soft tissue. If you get a bulkier person with a lot of soft tissue, you might be getting a super squishy soft tissue end feel much sooner than you should be. But yes, it's usually a soft end feel for elbow flexion. Again, same landmarks or same process. I'm going to take him to end range. I feel a soft end feel. That looks like it's about 160 degrees to me. I'm going to bring him back, get him relaxed, take it to 160. Doing okay there? Any pain? Palpating for those bony landmarks. And I was off. It's actually 152. So I'd say his 0 to 152 degrees of elbow flexion.
Is the moving arm still the radial?
Yep, radial styloid. Yep. Questions about any of that? Okay, let's go ahead and practice that. So we have our